So one bug can be associated with many conditions. For example, group A strep associated with rheumatic fever, gut tape psoriasis, pandas, chronic fatigue, recurrent tonsillitis, and post-streptococcal glomerulonephritis. But then again, you might have one disease that has many causes. So psoriasis has been associated with food allergies, strep, Bacteroides, maybe viruses, maybe mycobacteria. So it can be a little bit complicated as you're working through your patient cases, again, to try and figure out where the underlying mechanism is. And so I think a lot of us who've been doing this therapy for a while, we kind of think of it both ways. We're looking at, okay, hey, our patient has a sky-high ASO titer. Let's think about the things that might be associated with. Is my patient dealing with one of these issues? Or if they come in complaining of gut tape psoriasis, I'm thinking about, well, what kind of things do we know are known triggers? So again, this really kind of helps us hone down where we need to start with the therapy. So intolerance itself is often due to some sort of, we call it a catalytic event or circumstance that causes immune agitation. This could be a vaccine, it could be a viral illness, some sort of trauma, pregnancy, some sort of stress. And we differentiate a catalyst versus a trigger. So a trigger is something that's usually there on an ongoing basis. So for me to differentiate, the catalyst is kind of that isolated event. The thing that happened, it's a one-off, you got in a car accident, you got divorced, whatever happened, and that kind of set things off. A trigger is usually something that's there persistently, whether it's a chemical exposure, food allergy, some kind of change in your gut. But this is an ongoing thing that the body is constantly trying to keep up with, where that catalyst is something that just kind of happens in a while. And as we're working through our case, we're trying to figure out what's the catalyst, what's the trigger, because again, that's going to help us define where we need to start with our therapy. Interestingly, the catalyst is usually not the antigen that you want to use to start your treatment. You really want to try and find out more what the trigger is. I've done this mistakenly where someone told me about, oh my gosh, I got this terrible strep throat, and then I just never felt well since. I'm like, oh gosh, it must be strep, and I treat just the strep, and I get no really good clinical response. So that may have been the catalyst, but maybe there was a food allergy or something else underlying it. So again, it's good to understand the difference between these. So if someone's got food allergies after they got mono, if you just treat the mono, you're not going to get rid of their food allergies. So you really have to go back and look at that trigger. And I'm a naturopathic doctor, so detox is kind of our thing. And I've heard other people, well, if we just detoxify you enough, that's going to get rid of all your allergies. It helps, and certainly it's a good part of a comprehensive treatment plan, but it doesn't inherently change this immune mechanism that's flipped. So using some other type of immunotherapy is going to give you much better clinical results. So ultimately, our goal is, we're trying to restore the immune system, back to a balance. And it's interesting when you look at all the immunology research on, Th1 and Th2 balance. And now, Th17's become a very big, plays a big role now in how our body responds to microbes. And we always think of it kind of being a seesaw, teeter-totter, and of course, it's way more complex than that. But the one thing we see consistently is that autoimmunity and allergy is that, your cells are really in a Th2 dominant state. And of course, all these labs are research done. They're not, I don't know of any practical lab that really measures this. We just kind of know this from the literature. But ultimately, what we're trying to do is we're trying to downregulate Th2 response, upregulate Th1 response, and get more balance in the immune system. So the antigen selection itself is going to be based on the symptoms or disease condition. I think a lot of us who are doing it, we're looking at your clinical history. I actually do a lot of lab testing. I was a clinical microbiologist before I was a doctor, so I love lab testing, and I think it gives me a lot of useful information. So we have to look at where we think, or what microbe we think is the most likely causing the problem. We also have to consider what tissue or molecular target is affecting the person. We have to look at commensal organisms. Are they also immune targets for self-antigens? And then also just looking other systemic issues in the gut. If you've got someone who complains of chronic gut problems, inherently they're probably going to have chronic immune problems. So that's going to make it more challenging to do just LDI by itself. You're probably going to do a lot of other things to help support gastrointestinal health, repair intestinal hyperpermeability, and things of that nature.